Morning, everybody. Okay. Hungover? Yeah? All right. Day two. People are always a bit hungover in these sort of meetings. But anyway, welcome to Berlin, and welcome to the Humanitarian Congress. So this is the first session. So first of all, I want to thank you all for showing up this early. Now, this session is on reforming global health, balancing humanitarian urgency with long-term systemic change. Right? Just to frame the discussion a bit, it's ultimately about who wields the power, who reaps the profits, and who sets the priorities, right? So, and these are not new questions. So they were asked in Alma-Ata in 1978, when the international community made a commitment, radical at that time, and it was never really fully honored, that health was a fundamental human right, inseparable from an equitable international economic order. So health for all by the year 2000 was the promise. But what followed was structural adjustment, the dismantling of public systems, the imposition of user fees, and the systematic subordination of health to fiscal discipline. The vision of Alma-Ata was not overtaken by events, it was defeated by interests. Now, this defeat was not accidental, it was organized. Over the decades, since decision-making power and financial control in global health have been progressively concentrated in high-income countries and in the hands of a few private actors, development finance institutions, pharmaceutical companies, insurance companies, new foundations, and now even hedge funds, whose accountability runs to shareholders and to donors, not to populations. Intellectual property rules designed ostensibly to reward innovation have in practice protected returns on investments above anything else. Now, trade agreements were structured to extend monopoly protections. And when challenged, the response was process, more platforms, more summits, more multi-stakeholder dialogues, forums that claim to govern global health while ensuring that the most who need to shape it were not even in the room. At the International AIDS Conference in Durban in July 2000, Dr. Peter Mugenyi, who's a Ugandan physician and HIV researcher, put it very precisely: where are the drugs? The drugs are where the disease is not. And where is the disease? The disease is where the drugs are not. That gap between where the burden falls and where the decisions are made, between where the profits accumulate and where the dying happens. It's not a coordination failure, it's a structural feature. It was true in 2000, and it's also true today. Now, Mariana Mazzucato and the WHO Council on the Economics of Health for All named the underlying inversion. The economy has been asked to determine what health can afford when the relationship must be the other way. The economy must be restructured to serve health. Right? Not health rationed to serve the economy. That this formulation still reads as radical nearly 50 years after Alma-Ata tells us something about the distance between the aspirations and the architecture that we have built in the last 47 years or so. The crisis we are now in is not simply one of privatization, it is one of financialization. The deeper reorientation of health systems towards generation of financial returns in which development finance institutions mandated to serve public goods have channeled resources into private intermediaries with limited accountability for health outcomes, and which debt service obligations have hollowed out the fiscal space of governments that might otherwise have built the systems the populations need. Uganda, just to take one example, spends 75 cents of every tax dollar on debt repayment in 2021. And the figures come down a little bit, but it's pretty much at that level, leaving almost nothing for health. Right? Joseph Stiglitz and the G20 Committee on Global Inequity have documented where this leads. Between 2000 and 2024, the richest 1% captured 41% of all new global wealth. Inequality, the committee concluded, is not a given, it's a policy choice. The ODA withdrawal now underway does not arrive into a neutral situation. It arrives as an accelerant to systems already made fragile by decades of these choices. So that's the point that I wanted to make, that we talk about cuts, but it doesn't happen in a vacuum. Now, the spaces where global health is discussed have not confronted this honestly. At Davos and at the World Health Summit in Berlin, civil society is assigned to the listener's position, if it makes into the room at all. We have all heard stories about people not even getting visas to attend these meetings. Hedge fund managers and pharmaceutical executives occupy the podium. Much of the funding comes from private sector, and these are forums hosted by the very governments that block a patent waiver while championing a pandemic treaty. Process has become a substitute for substance. Multi-stakeholderism has become a mechanism for private sector access to policymaking rather than democratic accountability. Now, these are not neutral venues. They reflect and reproduce the same power asymmetries this session is here to examine. So this is the context in which we meet today, not to manage decline, but to ask the harder question. What would a global health architecture look like if it began from the needs of populations in distress, rather than from the interests of the institutions that we have inherited? And I would include humanitarian agencies in this as well. What would it mean to take seriously, at its 50th anniversary, the claim of Alma Ata that right to health is inseparable from equity and justice in the international economic order? So we're not short of diagnosis. We have been diagnosing this correctly. People have been talking about this for a long time. What has changed is that the concealment is gone. The vulnerability is now undeniable, not just in communities that humanitarians assist, but also in the richer societies that wield power in global health. So the question before the panel and before this room is whether that undeniability finally changes what we do, all of us. So to discuss these issues, we are joined by three very accomplished and thoughtful practitioners. Sandrine Chopin is General Coordinator for Doctors of the World, Médecins du Monde, in Mykolaiv in Ukraine, where she leads humanitarian health operations in one of the most active conflict zones in the world today, working with local partners to sustain care for communities under sustained attack. She brings to this panel the daily reality of what it means to deliver health in a system under siege, and the hard questions about what the international presence enables and what it forecloses. Now, Dr. Faiha Dafalla is joining us from New Haven, Connecticut, is a physician and public health specialist who until 2022 served as the Director of Health Planning at the Federal Ministry of Health in Sudan, where she led the development of National Health Sector Recovery and Reform Strategic Plan and managed Sudan's Gavi health system strengthening portfolio. She's now a postdoctoral associate at the Yale School of Public Health, and she brings to this panel the perspective of someone who has built national health systems from the inside and negotiated with the international actors who arrived to support them. And Dr. Hassan Saeed is a humanitarian medical professional with over a decade of experience in global health policy and emergency response, currently serving as intersectional humanitarian affairs manager with MSF in South Sudan, and is also the co-founder of Decolonize MSF. His work examines the colonial power structures embedded within humanitarian organizations and makes the case from the inside for a fundamental shift from a charity model to one grounded in local agency, equitable partnership, and the redistribution of decision-making power. So, excellent panelists, you will agree. So now let's move on to the session itself, and I'm going to start by a round of questions for each of the panelists. Okay. Shall we get started? So, drawing on your own experiences and a very quick sort of one concrete observation and one concern. Now it's not the time for analysis, but just quick observations. How are the recent funding cuts and political shifts in global health affecting people in humanitarian settings today? And what worries you most? Maybe I start with Sandrine and go to Fala after that.
Thank you, Yuni. Good morning, everyone. I'm going to bring you straight into Somalia. What stays with me is not a story of failure after the disruption of funding. What stays with me is the patient work of Somali health professionals, community health workers, colleagues from community to community level to ministry level, health professionals who worked relentlessly for years. I spent 4 years there. I could see the work they were doing to try to integrate vertical program. We are talking here about the Gavi Global Fund, but also the nutrition program. All these programs were run separately. They had their own supply chain. They had their own human resources. It was daunting. Then they work relentlessly to try to integrate this into a reform with a package of health services, EPHS. And it moved, it worked. It was slow, it was difficult, but it was real. And it is exactly the kind of work we say humanitarian development nexus is meant to do. But when the funding collapsed, that integration work is the first thing that went. By the end of 2025, UNICEF wrote in one of the reports that 113 nutrition sites had closed and more than 100 health facilities. It's gigantic at the scale of a country and knowing about the needs. Then the consequences, you see it already. We are already talking about drought and famine and disruption of health services, disruption of supply chain. And we start all over again. What a waste. Ukraine is very different. The system works.
We'll come to Ukraine in a minute.
Yeah.
Okay. So Somalia, I think what you painted a picture is quite stark. I mean, a lot of work has been suspended, and there are real consequences on the ground. Yeah.
And if I may compliment on Somalia, tremendous work.
Yeah.
Both by donors.
Yeah.
It was one place where you had emergency donors and development actors.
Yeah.
And you could see that the famous nexus was functioning.
You're right.
But it stopped too early.
Yeah.
Then we go back to square one.
Yeah. And so coming back to Faya, you've sort of, from within the Ministry of Health, you probably have observations on how this has impacted your work and the system as a whole in Sudan.
Yes. Just drawing on that, Sudan entering its 4th year of the war in this April. And just looking back in 2025, which is the highest need was financially where $4 billion was needed for humanitarian assistance, and only 6% have been funded by March, and half of that was U.S. application. So when I look at this, I just see that that cut of the fund has not just dipped in the resources, but I think of all the population, all the people who are affected. I look into the IDPs, the females, the displaced, the disabled population. And now there is returnees who are coming home where there is no actual infrastructure. So what worries me the most are the impact that we see at the community level, not only the national and the local level or the impact on the organization, but on the community initiative that is built and funded by those initiatives. For example, we had what we call community kitchen, where they are providing meals in the places where it is hard to reach. At the beginning, before the cut-off fund, there is about 1,400 community kitchen around Sudan in the conflict-affected area. And since the cut, 900 of these, more than half of them, have been stopped. So you can see now families who have those access have those access.
Okay.
And I think what worries me most is how are we dealing with this? Which is what's really keeping me awake. How are we dealing with this precedent where the fund is cut suddenly, and how the people who are in the most need are already underfunded, and now they are having accessible impact.
Okay, so whatever little funds they have, they don't have it anymore, and so you're going deeper into precarity in Sudan. And maybe you can paint a picture from your last, where you were in South Sudan, and perhaps you can talk about your one big observation and one big concern from the current situation of funding cuts.
Sure. So first thing, just a quick clarification. I was the medical advocacy manager based out of Juba in South Sudan. And I was there at the time of the funding cuts. So already based off of so just to give a context of South Sudan, it is the poorest country, GDP per capita in the world. Already there is a system which significantly struggles from systematic issues. MSF has been in South Sudan for over 30 years as a humanitarian organization. My first vantage point that I could see was the system was already struggled. It was not a very well-functioning system. There's hyper-NGOization of the entire health system. Different parts of the health sector, of the global health avenues are being taken care of by different fragmented healthcare entities. And on top of that, the nature with which the health cuts took place and overnight led to such a chaos and such confusion within the system. First, initially, there was this information that came out that life-saving aid would not be cut. And then what is defined as life-saving? Was nutrition life-saving, for example? That was a question. Eventually, the US State Department clarified, okay, fine, nutrition is a life-saving endeavor. But at the same time, when they did allow nutrition services to continue, what ended up happening was you had tons of ready-to-use therapeutic food sitting in warehouses, but there were no budget lines for transport. There were no budget lines for making sure that ready-to-use therapeutic food is able to get to the clinics where the patients are. And as a direct result of that, even though on paper it said nutrition aid is not cut, but in practice, the nutrition supplies were not able to reach the populations which they were meant for. And it's just the brutal overnight exacerbation of already such a precarious situation within a struggled health context that was just devastating, and there were far-reaching consequences that, I mean, this is one concrete example of what I had witnessed and where we had to step in to generate funding and generate resources to mobilize them.
Yeah.
But there were so many other things just like this,
Yeah.
which basically never met the news cycle.
Yeah. So massive disruptions. So let's go a little bit into sort of a little bit more detail. So Sandrine, you're now working in Ukraine, right? You're working with local partners and in areas that are still under active attack, right? Where the Ukrainian health system is damaged, but also it's functioning to some extent. So from where you sit, how does the distance between the decisions, where the decisions are made and where care is delivered, what can you actually do, and where do you see the biggest constraint in action, in delivery?
Yeah, first, Ukraine is a very different setting. In Ukraine, the system is working. Hospitals are functioning. This is working. They had a health reform in 2018, and unfortunately the war happened in 2022. But the reform was there, family doctors, primary health care, it was there. But the issue with the funding cut, it's like now when a woman has an hypertension in the south of Ukraine, is this a basic need? Is she allowed to get the medicine? Who is purchasing the medicine for specialty? Because all the donors want to do primary health care, but sometimes they limit really the commodities to the basic.
And who are the donors?
The donors, it's definitely European Commission is one of the big donors. Then there is also different European governments. Recently, the US, through the country-based pool fund, 134 millions that they want to localize and be implemented in 6 months. Then there is different, there is a vast set of donors. But the main issue there is that this reset, prioritization, hyper-prioritization, what you call localization, it arrived at a very convenient time. It's just sometimes another word for abandonment or withdrawal. And that's really what worries us with Médecins du Monde, because we need still to address the basic needs. And regarding your question, I think the problem is when apparent functionality, because an hospital functioning doesn't mean that we meet all the needs. And one of the constraints is when apparent functionalities is hiding many unmet needs. Secondary care is not funded, referral pathway is not funded, the care for victims of rape is not funded. There are so many issues which are lacking funds on the basis that it's maybe not humanitarian. There is also a different level of humanitarian need in a European country like Ukraine. It's very different if you are standing on a region in the front line, or if you are sitting in Lviv or Kyiv. All the country is under attack. The health facilities are under attack. They are destroyed. More than 2,000 attacks on health facilities since the beginning of the war. However, it's very different if you are sitting in a small village or in a city like Kherson under constant attack, drone attack, artillery attack, the drone disseminating landmines on the vicinity of hospital. The picture is grim. I don't want to get the mood down on the morning, but the picture is grim. Then what do we do? What do we do for that? The system is not catering for that because most of the donors, including ECHO, recently questioned if Kherson on the front line was humanitarian. Then when you get to that level of lack of understanding on about the field reality, yeah, you question. The last issue I will mention is that the system is strong enough to save life. But why is it strong enough to save life? It's because of the commitment of the human resource for health. A lot of human resource for health are now mobilized. They are on the front line fighting for their countries. But the other vast majority, mostly women, they stayed behind. I'm going to talk to you about Tatiana. Tatiana is a pediatrician. She's sitting in Kherson. She's the head of the regional health system in this region. She stayed there. She has a son. He was 3 years old at the beginning of the war, 7 years old now. She stays there. But is it fair that we abandon them on the ground that it's functioning and it's going to break, and how much it's going to cost to rebuild? That's one of the questions. And it's something also I wanted to ask my colleague about Sudan.
So, Sandrine, something you said about donors insensitive to or not fully recognizing the needs on the ground, even the conditions on the ground, like Kherson under constant attack and questioning whether humanitarian assistance is needed in a place like that. I wanted to ask Faiha, you've been in from the Ministry of Health. How have you experienced humanitarian agencies, emergency response, even when well-intentioned, how do they reinforce power imbalances that they claim, at least on paper, that they're working against? How have you experienced international donors and humanitarian agencies that come to assist? How do they help with your work, or are they standing in your way sometimes in providing the care that is needed on the ground?
From my vantage point, I see that the imbalance is often a natural byproduct of the emergency itself, the emergency situation. Even in the situation where there is no actual emergency, there is always a need. So this inherited gravity in relationship between one in need and one providing, irrespective to the intention. So even when we frame the response as technical or neutral, it is deeply political by design. Somewhere in this in the landscape, somewhere there, where the decision is made of where the fund goes and how it is earmarked, even if it's not really explicitly. So the imbalance is not just only in who has the money, but it's also in who is defining what's urgent, what is important at this moment. And also at the same time, I believe the balance cannot be found in the power, because the power there is an imbalance in the power, but in how we navigate its pros and cons. Because, for example, the interventions, even if at the system level or at the population level, is very well earmarked when it comes to the external funding. And the external funding also does not really tend to solve issues of the system that is very deep, like salaries or retention of the human resource. So I'll give you one example that features how the global response has the ability, or sometimes that see that power imbalance. For example, those global responses or organizations, they are very good in mobilizing local talents and experts. And they are the best in doing so, whether it's operational staff or admin staff. So they are localizing their action, which is very good because it is needed. They are the local expert. They are the one who are able to navigate the corridors of the trust between the communities, or speak the language, or very good in accessing what is exactly the need. But at the same time, the hidden cost that is not really negotiable, and that is I personally sense, is the decision space gap that is the experts face when they actually became part of an external organization, whether it's international or not. So they have that shrink of the decision space, although they are the experts. So they're following a protocol of another system. They have a least power and authority to mobilize and immediately react. That is something we face. The other thing also, because usually the external fund tend to provide a career path or salary that is not competing, the national government, or usually the systems, especially when they're in distress, they're not able to compete with it. So you see that internal brain drain. So suddenly the offices at the governmental there is no one to actually to execute, and then there is a natural creation of a parallel system that is where the NGOs actually has to take as a consequence sometimes. So they're literally emptying the best staff out of the national system.
Yeah.
So the existing the architecture of this third party, it's really you can see the impact of those power, even if it's not spelled out.
Yeah. So humanitarian assistance can leave health systems depleted because the best staff are poached or leaving for better salaries, better conditions, etc. Right? That's one outcome. Now, I just wanted to ask Hassan, you've been an internal critic as well. Maybe you can reflect a little bit on how humanitarian agencies set priorities and whether they actually respond to the needs of the people. Is there a gap between the priorities set by agencies and the actual needs on the ground? And if so, how can we address that?
So let me just preface by saying that humanitarianism is certainly a very noble endeavor, and there will always be times when surge capacity is needed in order to fill gaps in the system. However, that surge capacity has to be limited, time-bound, has to have very strict entry and exit modalities, and they have to ensure that the system is handed over to a local healthcare actor so that it could be run in a long-term sustainable manner. Now, I just mentioned South Sudan. MSF has been in South Sudan for 30, 40 years. 40 years of a humanitarian emergency response is certainly too long a response. At some point, we should stop and think, are we running a parallel health system to the local Ministry of Health system? Is it the fact that all the investment that we did over the years, just to give you an example, we just spent 4 million euros annually on jet fuel alone in South Sudan, airlifting, all of the drugs, staff, resources to our projects. Now that's a huge amount of money just on airlifting stuff. And how much of it could theoretically have been spent? I'm not saying it would be the responsibility of an international NGO, but just imagine if the same amount of money could have been utilized to spend on infrastructure that could have led to a long-term sustainable condition of the system. In that particular case, even if you get to leave the country, you still leave behind trained staff, a trained infrastructure, a capacity which could then continue on with limited resources and limited effort. But at least you leave something behind. Yeah. And yeah, that's where the challenge is. The humanitarian interventions are just too cost heavy, too top down, and more often than not, community engagement and understanding the actual needs of the community is an afterthought rather than something which is done at the very beginning and included as a part of the programming.
Sadako Ogata famously said that there are no humanitarian solutions for humanitarian problems. Exactly. I mean, what humanitarians respond to are political failures. And Sudan is a very, very good example. 40 years later, we put out a few fires, but the country is still burning in a big way. Sandrine, you had a question that you wanted to ask Hassan. Go ahead.
Yes, I wanted to ask you, Hassan, What was the situation when the funds were cut in South Sudan?
I mean, like I mentioned, the country is so heavily reliant on these external actors, which basically run the entire healthcare system of the country, everything from emergency response for cholera down to routine mother and child health programming, nutrition programming. It's all run by the health cluster. And when the system is so dependent on these foreign entities, and all of a sudden these foreign entities lose their funding overnight, it's all of a sudden there's a domino effect. The international organizations started firing their staff within 48 hours notice, and immediately there was a state of chaos and confusion. There were people who were expected to be in a particular position were no longer there, and that left a lot of gaps within the system. One classic example is, so the UN has, the Humanitarian Air Service is used by all the entire humanitarian sector to airlift their staff as well as supplies within the humanitarian zones. And when UN has got its funding cut, I mean, it was declared as non-necessary funding, all of a sudden that meant that other humanitarian organizations which were reliant on the transport services were no longer available. Similarly, the Global Fund, for example, had major funding cuts, and the biggest funding cut that they received were community health workers. They were deemed as, because they're HR, they're too costly. And that is essentially the most important part
the
of
basic
building block, which was historically took decades to be built in order to mobilize, train resources to reach those communities in far-flung areas. Now, all of this capacity that was built over decades is the first one to get cut. And it's such a pity that, you know, all of the wins were just undone overnight.
And if I have, maybe you have a comment from the Ministry of Health perspective, how sort of what was affected the most and what will be the most difficult to recover from this sort of round of cuts. And not just the cuts, but the structure as it is affected by conflict, but now on top of that affected by cuts as well. What will be your biggest challenge when the conflict ends?
I think the biggest challenge that can be faced is in the location where there is no actual system, but they were dependent on the external fund and external organization. Because the current practice, there is no humanitarian development at the same time. So it feels like there is a stability, there is a sense of achievement, and there is a lot of achievement have been done, a lot of opportunities, but that will be a shock when everything drawn, if it's not handled carefully. Because the cut of fund now, so we saw that that shock already, they have been felt, but we can imagine if this hasn't been contained as soon as possible, it will be catastrophic to some places.
So let's just look ahead now. I mean, we've sort of gotten, you all sort of outlined some critical failures, that it's not just about the cuts, but it's also about how donors operate, how humanitarian agencies operate, and years of dysfunction that we're talking about. But we are at a moment. I live in Kenya, a lot of Kenyan civil society think of this moment as a decolonizing moment where change can happen. So think about from that perspective. Let me sort of ask you, Faiha. So in a really reformed global health architecture, what role should national and local health systems play? Not as implementers of internationally designed programs, because you kind of hinted in your previous response that sometimes you're responding to donor priorities rather than your own priorities. So how does that how do you get back to a position where you can set the agenda, you can set the priorities, and you can implement it? What needs to change for you to be able to do that in the Ministry of Health?
I think there is two tracks. The first track is at the national level, and I think the current financial cut, although it was really catastrophic, but it was an eye-opening. And for example, in Sudan, they started to seek other avenues for funding that is bilateral or non-traditional donors, mobilizing local resources. So this is the start. So the countries need to be able to find avenues where they can have diversification of the funding and build the national funding capacities. And also they need to advocate and actively participate in priority setting at the global level and architecture of the systems. For example, we have the policy of hit and run model, for example. This doesn't seem to be effective on the long run, and this is, as I mentioned, when the cut or the crisis subside, this is the first thing that we feel when there is no actual build on the ground. At the global level, I believe there's a lot to be done, and the literature already catching up on that. But I still want to mention something very specific: is the trust. The trust in practice, not the trust like feel-good trust, but actual trust in practice, and that's what's we manifest in a lot of requirement, earmark funding, all of those delays in the implementation. So I think from the global level, they need to actually practice the actual trust when it comes to the local or the national response. The other thing that I find really important is the design of the system itself. So what I see is the system globally is designed for a well-developed national countries, I would say, more stable systems. So that's why there's a lot of requirement, there's a lot of expectation when the countries are in the worst situation. So even sometimes when the country finally receive the fund, because of the requirement, they found it very impossible to absorb all of that fund. And there's the issue of the time frame. There is money, there is a need, but there's a time frame. So there's a lot of models that is practiced, need to be changed at the global level as well. And also there is terminology that we're talking about moving from localization to health sovereignty. So the countries now need to own and to enforce their global agenda, their national agenda. So this is what I would take for now. Yeah.
So for the audience, can you tell us what percentage of Sudan's budget is allocated for health, and what is that at the moment?
I don't have the statistic number at the moment, but at the moment, as health is at the priority, which is something wasn't really the case before the war. Yeah. They are prioritizing that. So there is a lot of funded being mobilized for infrastructure, for retaining of the health workers, all a kind of building of the hospitals, infrastructure. But the numbers I don't have at the moment, but they are.
Like what, 5%, 6%? You don't know.
Difficult to mention at the moment, yeah.
So Abuja Declaration, sort of the agreement that a lot of African countries came to was to allocate 15% of their budget for health, education, social services, etc. Very few countries really reach that level. And so a lot of countries are reliant on overseas development assistance, but the budgetary allocation for these services are quite low. Now, coming to Sandrine, I mean, I think Faiha is very clearly, from her perspective, what it needs for government to take ownership of their own agenda and how to implement it. Do you, in the position where you are, what are the tensions from an operational perspective? And can you sort of lay out some principles that should guide this reform going forward? I mean, it's a big ask, but if you can think through.
Thinking about reforming the system, it's first, as Farah mentioned, it's the time frame. It takes a long time, and we cannot have a funding cycle which are too short. We need multi-annual, flexible funding. The funding for reforming the health system need to be granted at ministry level. And I think it's where maybe collectively we need to change the way we are doing business. We humanitarian organizations arrive in a place and do what we know how to do best, deliver. We deliver medicine, we deliver nutrition, we deliver water, we deliver. But we have a way of working that may disrupt an equilibrium that took a long time to establish. In Ukraine, the system is functioning, as we mentioned before. They have specific needs that are not covered by the humanitarian system because it's not really the way we are doing the business. Their need is not covered by development funding architecture because it's not yet in place. Because development donor thinks, yeah, it's an active conflict, it's not yet there for development. The World Bank is there, but we know how long it takes to engage. Then for me, a good reform will be a reform that flows through the existing structure, not around, and which is really pulled by the local authorities, by the ministry. A second principle will be don't romanticize handover. Don't romanticize localization. We all want localization. But yesterday we were talking about localization with OCHA, and it was great. But what we don't hear when OCHA talks about localization, it's, for example, he was saying that 2/3 of the country-based humanitarian funding went to localization to local NGOs. In Ukraine, the analysis shows, for example, that 57% of the ECHO budget in 2025 went to UN agencies. Then when we talk about localization, what is really the localization about? That's something we should keep in mind in our principles. And the last one, yes, it's continuity. We cannot reform thinking, okay, let's stop and reform. No. We need the continuity of care. We need to make sure that the people we are aiming to serve are served. And then we do the reform around it. We don't stop from one day to another vertical program. We make sure that they are integrated in a package of health services. That's my
I mean, something that we always talk about humanitarian assistance is that you're not going to sacrifice lives today for a system that might be built tomorrow. So, Hassan, as a humanitarian actor, what do we need to do different? I mean, we are well-intentioned, at least we think we are well-intentioned, but we know what well-intentioned European missionaries did in Africa and Asia 200 years ago. So good intentions are not enough. What is it that needs to change in the way we work? Because also an emergency does not mean that you can ignore the long-term needs of any country, right? So what needs to change in the way we do business, the way we act? So be as critical as you need to be.
I think the road to hell is paved with good intentions.
Yes, exactly.
I think if we come down to the bare bones of what we're discussing, it comes down to the needs of the population, right? Whether it comes through the vehicle of a humanitarian donor or a development donor, the bare bones of the matter is the needs of the population, particularly the healthcare needs of the populations, need to be met. Now, it is true that historically the way we did things were too top-down, too us-centric rather than the population-centric. We decided what the needs of the population within a humanitarian system or a humanitarian intervention need to be, rather than asking the population. And I think it doesn't take much to realize that if we continue on with this tangent, we are burning through resources which are such a precious commodity at this point in time, when the entire global health system architecture is struggling with resources. And the few organizations which have the luxury of having these private donations resources, they really need to think, how do we make sure that this pool of resources that we have, how do we make the biggest bang out of the smallest buck? And that happens only when you are actually talking to the populations, listening to them, understanding their needs, doing programming which is tailored, suited to their needs. Don't come in with big flashy programming, don't come in with big flashy Land Cruisers, but basically have an intervention which is suited to their needs and something which can be carried forward. One unfortunate reality of the funding cycles, as everyone mentioned, unfortunately the funding cycles are at times so short that what ends up happening is this frenzy of wanting to spend for the fear of not underspending and not getting any resources later on. That often at times what you see at the end of the years, at the final quarter of the year, is a spending frenzy to buy Land Cruisers, to buy video screens, to renovate the conference rooms. And then that is essentially misuse of resources. That's an inefficient utilization of resources, and it's essentially like a tail wagging the dog rather than the other way around. And that sort of a system, when you have that sort of an accountability mechanism which disincentivizes efficient use of resources, I mean, you have to stop and think, okay, we have a problem here. How do we solve this problem? I mean, if there needs to be earmarked funding, it has to be over a longer period of time, and it needs to incentivize efficient resource utilization.
So my advice to some of the recipient countries have always been, your biggest power is to say no. We do not accept these conditions and we do not accept this money, right? And that, very few countries actually exercise that because they feel that money can do so much. And if we say no to this money, we might not have more later. I want to open it up to the audience, but before that, any of the panelists have questions for each other? No? Audience, are there questions? Okay. 1, 2, 3, 4. Okay. All right. Keep your questions short, and if you want to direct it to one of the panelists, please do.
Thank you so much for the interesting talk. I think I have 2 questions. The first one specifically for Sandrine. You mentioned that in Somalia, actually the nexus is working well. And I think it's really key, right? Because it needs to have the donor, the development actors, and the humanitarian actors working together to build the healthcare system. So can you tell us how it worked, what made it successful, and what insights could be applied to other situations? And then I think the second question, maybe for everyone, is I think you mentioned that it's necessary to look at the needs of the population. But I suppose the complexity of healthcare is that there are so many needs and so little resources. And so the decision-making must be at the hands of the national governments and the local people. And so I want to understand how, for example, MSF, you've worked in South Sudan for 40 years. How can that decision, it was taken by MSF, how can you then shift that decision-making to the national actors and to the local communities?
Yes. We'll take one or two more questions, and then we will come back to the panel. Yeah, there's one behind there.
Yeah, thank you. Well, I think my question is kind of trying to look at health systems from the lens of non-communicable diseases. As we will talk about systems, with a big part of that is also primary care, community interventions, things that all of you have actually mentioned. And on services being affected by global cuts, how were NCDs affected, especially that they were always probably historically known as being under prioritized or not really kind of funded enough? Maybe it depends from one organization to another, but probably I'm more interested from a system level. Probably, Dr. Fayha, you could answer that. And any kind of indicators that have been used, maybe Dr. Hassan, you can kind of reflect on that. Being in South Sudan, MSF has been in South Sudan for 40 years. NCD services there, how have they been affected by the cuts? And also, any indicators of preventing NCDs, preventing complications of NCDs, and how the health system has been resilient on NCD services in South Sudan.
All right.
As well.
Well, we'll take one more question here. Here. Yeah.
Hi, thank you very much for your presentation. It's really interesting. I have a question for Sandrine. In Europe, the agenda is moving towards preparedness for conflict. So Ukraine may be looked at as a blueprint for humanitarian interventions in a functioning healthcare system, for example, as well as many other functioning systems within the country. What is the lesson learned in terms of describing the complexities of needs, of medical needs in particular, that you hinted to as donors? What can we do as humanitarian actors to be better prepared for that kind of complex crisis? And what are the indicators for a responsible exit strategy? Thank you.
All right. So we'll go to the panelists. Just two notes I want to make. One is, yes, MSF has been in Sudan for 40 years. But don't forget, for the first 25 years, it was Sudan. And the last 15 years, it was South Sudan, right? And now we're talking about a very young country with very little resources. And a lot of the times, if you want to talk about health system, you have to have someone in control nationally to be able to have that conversation. And sometimes in places we work, we don't always find that, right? Just to keep that in mind. That's not an excuse, but that's something that we need to keep in mind. Second thing is, health system is not just one thing. It's not a static thing. It's a very political idea. The health system in any country is a political decision. Even in America, even in the United States, if you elected Bernie Sanders, you would get a different kind of healthcare system. And if you elect Trump, you get a different healthcare system, because it's inherently political. And who are we to make that decision as outsiders, right? So that is also why it is important that we have to have these conversations with the people we are there to assist. So let me go to Sandrine first. There were questions on Somalia, and then there were questions on Ukraine for you.
Thank you very much, Abby. It was working. Sorry to disappoint, but it was working. Humanitarian actors, development actors work together to try to integrate all those vertical programs that were draining all the resources that we discussed also here, and make sure that it was more efficient. I think I added the piece of the P of the peace, of the nexus. Because having a system working in a country is having people being served in remote area, having access to healthcare, it's human resource working, community having access, and that's a dividend for peace. I think peace is built there at community level. It's not always like it is based on a political decision, definitely, but it translates immediately. Those engagement, political engagement, translate immediately at community level. Yeah, unfortunately, it's not all gone, but it's not going very well. To come back to your question, thank you very much, on preparedness for conflict. Ukraine was prepared, I guess, because we have been preparing forever they exist. It's like South Sudan. They were at risk from day one, and they prepared. But preparedness comes with funding for preparedness. We've been advocating for the last 20 years for more funds to be dedicated to disaster risk management, to disaster preparedness. And as soon as there is funding cut, that goes first also. Then community level goes first, second disaster preparedness, and then we are again reactive rather than to be proactive in preparing, in planning, in stocking. Even now, some donors who accepted, like 10 years ago, they were accepting, for example, Médecins du Monde, to have a stock of equipment, health equipment, and stock of medicine available for emergency response. Now it's very difficult to fund that. They don't authorize. Then the lesson learned is we need to be prepared. Maybe we need to use our own funding to be prepared, to pre-positioned, and to stop waiting for the donors, for the institutional donors, to take action. I'm talking about this from my experience with MSF, where we were blessed to have private funds, and also from the perspective of working with Médecins du Monde, where we have a chance to have also private donors who allow us to have this independence, the capacity to act immediately upon a disaster wherever MDM is thinking it's worth or it's important. But not all the NGOs have this capacity.
But independence, there's no such thing as true independence. Yeah. True independence is the ability to choose your dependencies. You know, we are all dependent on actors locally, but that we make those decisions based on proper assessments, etc. Right? The question about chronic diseases and the health systems that gentleman asked. Do you have a response? Or to the other question, the second half of the question.
Yeah, I think you rightly mentioned that a country as young as South Sudan, I mean, there's virtually non-existent health system to begin with. I mean, the country has essentially been at war for most of its founding, and it has a functioning humanitarian development nexus as well, and that's hats off to the humanitarian endeavor that, you know, people still find a way despite all the fragmentation, despite the worst of the conditions. Different NGOs, local and international, continue to find a way to work together to fill the gaps. And they basically run the de facto health system, and it's semi-managed by the government. Now, when we talk about NCDs, in a place like South Sudan, it is already so down the priority list in a place where you have multiple malaria outbreaks, you have the active biggest cholera outbreak in the history of the country, you are currently in the midst of funding cuts for TB, HIV, you are massively struggling with you're massively struggling with the bed net distribution because malaria season is approaching. I mean, within that context, the NCDs are not even a part of the discussion anymore.
So it's still, in epidemiology, it still hasn't transitioned to...
Exactly. I mean, it's just the nature of the context hasn't allowed there to be enough stability within the health system for a topic like NCD to prop up.
And maybe that's a question for Fire, because I think in the north, they have that dual burden of, in some parts of the country, you have infectious disease epidemiology profile, and in other parts you really have to deal with chronic diseases and services for chronic conditions. How do you sort of balance that as a system with all the challenges that you have at the moment?
Yes, it's true. There is this double burden even before the war. And even before the war, the NCDs wasn't at the top of priority. There's a lot of initiatives that are coming up. But I would say in the design already in the humanitarian context, even the strategies that are used to the humanitarian response are not supportive to the NCDs. So when the fund cut happened, all the system has been affected generally. So the supply system for everything has been affected, the services, everything, the human resources. But the NCDs themselves, they took the biggest hit, I would say. For example, when the war happened, some location in the Sudan, in the country, there is 100% mortality of the people who's doing dialysis, because there is other needs, there is other prioritization. The cut, any disruption of the NCD's treatment or interventions, it's a bigger impact. So I would say, for example, in Sudan, there's other NCDs that is coming back when the system is starting to stabilize. You can see that his NCDs are coming back into the priorities list. There's interventions, and mostly I think the interventions will come to the NCDs from the developmental partners more than the humanitarian partners, and that is very important when you talk about the nexus. But because the nexus looking to the two arms, where there is humanitarian going on and there's a developmental that is looking to the lifelong effects of health impacts, and that is very important. And also, I really would like to respond to the question of the need of the population. And I think the need of the population, or the population needs, tend to be wide and tend to be very much, there's a lot of needs, and everything the needs. This happens when you don't include actually the population of the community, because the community are very good at pinpoint exactly within this list what they want to be done first. And this is not necessarily the situation when it comes to when an organization or a need assessment just being done, because they pick up everything. So I think when it comes to the population needs, when it is moved to the local authorities, to the local community, it will be easier to identify the gaps. The population tend to have different gaps. And we have done this during the war in Sudan through the support of the WHO. We went to the community because there is no much funding to do everything. We need to know exactly from all this list, what can we be done first. And with the community engaged into the decision making, into identify their needs, you'll be surprised of how they prioritize and how they actually help in bridging those gaps, even at the system level. They can return your human resource. Can they support you in building the infrastructure? So you're left with some resources to cover extra needs for them, for example. They can support in the supply chain. For example, in Sudan, in Jazeera, when there is the cut of the supply chain, they were the one who actually actively able to bring medicine to their villages they were able to return some of the health workers. They were able to allow other, for example, displaced health workers, they support the system for them to be engaged, and so on. So I think perhaps the transition from who is making that decision from an external actors to the internal actors is very important. And within the internal actors to go at the lower level with the communities. And that will ensure better need assessment and response.
I think both Sandrine and Fahab sort of put the finger on the notion of resilience. I think Ukraine, you have, despite all of the challenges of the last 4 years, I mean, an incredibly resilient system where people are able to come together and still deliver at a reasonably high level. And to a certain extent, I think that's also what Faiha has been talking about, that even in times of conflict, that the system in some places, in some communities, are able to come together and deliver. And this sort of also shows, the depth of systems, how they can recover from conflict, how they can respond in times of crisis as well. And so there you have opportunities for humanitarian actors to engage and sort of work with, which unfortunately may not be present in South Sudan. Given how young a country is, the resilience is very low. Maybe one question. Yes, one question here.
Thank you. Thank you very much. My name is Ines. I'm Director of Handicap International Germany, part of Humanity Inclusion Worldwide. I really thank you for your very inspiring presentations and discussion. And I thank Dr. Fayha for mentioning at least disabled people in your presentation. Now, all three countries you are referring to are in war, and the amount and the percentage of people with disabilities during war raises from 15 to 20 to 50% in many occasions. And people with disability in war are most at risk of dying and of being left out. Now, when we talk about reforming global health, how do you think can we ensure that people with disability are systematically included into the system, are consulted, are taking part in decision making, and are not left out as systematically as they are currently being left out? Thank you.
Thank you. All right. So let's do a round and also perhaps address that question, but also maybe your concluding remarks, and then we will close it after that. So maybe Hassan, we'll go with you first this time. Think about disability, but also a closing for the session.
Yeah. I wish I had an answer to that question, in all honesty. Again, let me just take you back to the context of South Sudan. A country so young, so struggled. 95% of the exports of the country is oil through a single pipeline, which is blockaded in the former north of the country, in Sudan. I mean, the priorities within that particular context, and you have basically an active civil war where the soldiers who don't die of bullet wounds end up dying of cholera. In that sort of a situation, it's just everything becomes such an immediate active priority, and mortality reduction becomes the primary priority of many of the humanitarian actors, just to save lives. And that in itself becomes such a momentous challenge within that struggled context, that everything else for the time takes a back seat. And I unfortunately also mentioned that disability is one of them. War-wounded soldiers, children who've been at war, injured during the war. I mean, all of these populations are just systematically, unfortunately, marginalized, and there's just not enough resources to go around. And that what brings me back to the conclusion of this discussion. I mean, sitting here in Berlin, many of us who live here live in a place of such excess, that thinking about
Excess or access?
excess.
Oh, right.
I mean, excess of resources, a place of such privilege, that to be able to think about those on the fringes is a privilege. But in a place like South Sudan, which is so poor, so desperate, so much in need, I mean, just barely surviving is at times becomes a privilege. And I think that's the frame I want people here to understand, that when we talk about funding cuts or humanitarianism or funding, I mean, seek to it that they are also living, breathing human beings just like ourselves, with the same needs as ourselves, same wishes, hopes, dreams for a better future. And at a time when we are not even allowing, or the situation doesn't even allow just bare survival of the population.
All right, thanks. Sandrine, I mean, Ukraine, I mean, disability is an everyday reality. I mean, the more, war injuries, etc., and
yes.
the context is...
Thank you for this question. In Ukraine, there is a silent tsunami arriving in the health facilities, and it's the reintegration of the veteran population. They are slowly, some of them have left the front line because they are injured. And when we talk about investing in a resilient system, while it's still holding, that's what I meant also. The system in Ukraine needs to cater for this large population of persons who will be injured. When we think about disability, we think about physical disability. There is more than 100,000 persons who have lost a limb in Ukraine over the last 4 years. It's gigantic numbers. None of these European countries are able to absorb the work it takes in terms of rehabilitation, physiotherapy, and so on. But it's not only that, it's all the psychological injuries, all the person who will suffer from PTSD. I mean, this constant bombing, the lack of sleep, 4 years, I mean, we are very humble looking at the work they are doing. And I think we need to continue the work. We need to make sure that persons with disability are included in our programming from the beginning. We need to think about vulnerability focal point. We need to make sure that this great idea of HI is mainstream through our programming. And we need to uphold to our word. I mean, all the European countries signed the UNCRPD. Then that's part of the deal. Then we need to be inclusive, and I think we are aiming to, not enough.
Yeah.
To finish, I will concur with my colleague. I think we need to stay driven. To stay driven doesn't mean that we collectively going to change the world. We try to shape a new health system together. We try to stop the waste of resources. We aim to do better, but we need to be driven and we need to be humble. Stay humble, look at the community. When you question if reforming health system is worth, go back to the field, look at the community, and surely when you wake up in the morning, you know it's worth.
If I have a very quick wrap-up.
Yes, I just wanted to say situations are of the conflict is getting worse globally, and systems where they are developed like in Ukraine or underdeveloped like Sudan and South Sudan, they are continuing to suffer. And I think as someone from the national level or speaking on the national level, I would call the global community, the humanitarian actors, the development actors, to come together and remember the mission. Eventually, we are all either international organization or national system. We are serving the population. And serving the population comes with a lot of responsibility that we need to shoulder together. Resources need to be allocated equitably and redistributed equitably, not to be driven by politics or any standard that not really speak to the mission. And thank you all for coming. I just think this is a moment where we need to stand and we actually put the reform that we thinking of in action.
Yeah, thank you. To your point, recently I was invited to join consultation between the Dutch government and civil society on funding cuts. And one of the points that I made was that now we are shifting funding from ODA to defense and to military spending, that defense spending, military spending should also include funding for the consequences of military spending. So in the situation like Ukraine, that is the consequence of war. There will be high numbers of people who are disabled, and any funding that moves from ODA to defense and to military spending should also, and I think that's a job of all of us as civil society actors, is to push governments to include the consequences of that spending also, you know, in terms of health consequences, mental health consequences, et cetera, et cetera. So I'm not going to try and summarize all that we've heard, but I just want to leave the room with just one thought, because it's the key point of the session. Humanitarian assistance can harm health systems. And not through malice, not through incompetence, but through the logic of the response itself, right? The speed, the parallel structures, the incentives that pull skilled workers out of public systems, as Faya has just said, the supply chains that bypass national procurement, the data that flows to donors rather than to ministries, done at scale. Over time, humanitarian health action can leave a system weaker than it found it, right? Haiti remains as a good example. We didn't talk about it that much, that we should really think about. The international response after the 2010 earthquake, and of course the cholera that followed it, was huge, right? But it was built around humanitarian actors with minimal integration into Haiti's own health system. Now, when the international community eventually withdrew, it left behind a system really depleted, because the health system was gutted because people left the health system to work for higher paid NGO jobs, right? And we left Haiti, or when the emergency was over, Haiti was less capable of governing its own health response than before the crisis began. So these are things that we need to think about. Now, this is not an argument against humanitarian assistance itself, but it is an argument for humanitarian assistance that takes seriously its ethical obligation to do no harm, right? And where harm cannot be avoided, because humanitarian settings, there is always some harm, there is an obligation to minimize harm, to be honest about it, and to take the responsibility for it, including the longer-term consequences of how the response was done and how we leave a context. Now, humanitarian actors also need to be clear-eyed about the power they wield, right? Over resources, over priorities, over the shape of care itself. It is not for us to decide what a system that we should put in place in the country. We should be there to support. Strengthening health systems does not only require funding and technical support, it requires the ceding of power. It requires the ceding of space and the willingness to measure success not by the scale of one's own presence, but by the growing capacity of others to lead without you, right? Replacing a health system is not the same as supporting one. The difference between substitution and solidarity, between a response that depletes and one that builds, is precisely what needs to change. So we heard from all of them today. They understand what the challenges are from inside. The question for all of us, and also when we continue to think about these things for the rest of the day, is whether the sector is finally willing to act on it, not in the next strategy document, but in the next response. So thank you all for coming today, and thanks to all of the speakers, and for joining very early in the morning, 3 in the morning in New Haven, Connecticut. Thank you so much. Yeah.